Welcome again, everybody. This is a 28-year-old female patient with an MRI that was performed to rule out demyelinating disease. The case is dedicated more for senior residents and urology residents, but juniors would find the anatomical part of this discussion useful. You're looking at a T2 image where fluid is bright within the ventricular system. Let's look at the flare where you suppress fluid. We know from previous discussions that flare is a T2 image where fluid is suppressed, so fluid looks black instead of white. Now, before we proceed with the quiz case, let's look at a normal case to discuss some anatomy. This is a T2 weighted MRI of a normal brain where you see fluid that is bright within the ventricular system. This is anterior, this is posterior, this is right, and this is left. This here is the lateral ventricle. The slit-like CSF space is the third ventricle. You see this connection here between the lateral ventricle and the slit-like third ventricle. This is called the foramen of Monro on each side. There's more discussion to the ventricular system that we've talked about in previous clips, but for the sake of this case, this is what you need to know for now. Vascular structures on T2 weighted images appear as dark structures, which we call signal voids, such as these two structures here. So these structures that run in the roof of the slit-like third ventricle are called the internal cerebral veins. You'll see the internal cerebral vein running from anterior to posterior, and then they meet together in what looks like rabbit ears here. And they form what's known as the vein of Galen, just a famous vein, which continues as the straight sinus. Another thing to keep in mind is the thalamus here on each side. So the slit-like third ventricle lies in between both thalami. This thin membrane separating the right and left lateral ventricular systems is called the septum pellucidum. You'll notice these soft tissue components on each side of the septum pellucidum that go all the way down. We'll talk about this even further. These two dots are part of what's known as the fornix, which is a C-shaped or an arc-like structure that we'll talk about further when we look at other sequences. Another thing to look at is the cortex, which is gray matter, and the deep white matter here. Remember, on a T2 image, the opposite to what you think occurs. The gray matter is bright and the white matter is dark. What I want to show you here is this communication between the right and left hemisphere, anteriorly and posteriorly. These connecting white matters anteriorly and posteriorly are known as the corpus callosum. This is what I want to show you on the axial images. Let's recall what we talked about quickly before we go to the sagittal image. We talked about the corpus callosum, septum pellucidum, fornix, internal cerebral veins, lateral ventricle, third ventricle, and thalami. Now let's look at a sagittal T1 MRI without intravenous contrast. It's T1, so CSF is dark. This is anterior, where the nose and paranasal sinuses are. This is posterior, where you have the back of the head. Let's start with the easier stuff. We talked about this before, but this here is the corpus callosum. This bend here is the geno of the corpus callosum. Geno means knee. This is the body of the corpus callosum, and this is the splenium of the corpus callosum. Beneath the splenium, you have this gland, which is the pineal gland, and then you have these components of the midbrain. The midbrain has two components, the posterior, which is known as the tictal plate, and the anterior component separated by the cerebral aqueduct. So you have the splenium of the corpus callosum, pineal gland, and the tictal plate. This small linear thing here is part of the internal cerebral vein. To show the internal cerebral vein better, I switched to a same study with contrast, and that's why you see the venous structures enhancing and appearing as bright structures here. So this is the internal cerebral vein on one side, going beneath the splenium and above the pineal gland, where it forms the vein of Galen, which continues later as the straight sinus. Now going a little bit to the side, there's this relatively unclear C-shaped structure here, which is the column of the fornix. That's the part of the fornix that we talked about before. To simplify what the fornix is, let's look at the lateral aspect of the brain. This is the temporal lobe. If you go from lateral to medial, the fornix connects components of the temporal lobe more centrally. To understand the fornix, I'm showing you here a coronal T2 image where fluid is bright. This is right, this is left, this is superior, this is inferior. Those here are the temporal lobes on each side. What's above that is the frontal lobe. The most medial aspect of the temporal lobe has a system that's known as the limbic system. You don't need to know this now. But following this area here, you'll notice that there's this C-shaped track that goes all the way anteriorly and forms these two columns. So this part here connects the medial aspect of the temporal lobe more centrally, and this is the fornix. To revise, this here is the septum pellucidum separating the lateral ventricles, and the tissue that you see here is part of the fornix, the column of the fornix. This is the slit-like third ventricle. And now that you know that signal voids represent vessels, these are the two internal cerebral veins that we talked about. The reason I described all this is because I wanted to talk about a structure known as the velum interpositum. Velum interpositum is basically a membrane that's created by the meningeal coverings of the brain. In simple terms, this membrane resides between the two internal cerebral veins and is located above the pineal gland that we described before, so between the internal cerebral veins and above the pineal gland. It is situated between the column of the fornix, which is clearly seen here, and the internal cerebral vein, which is not so obvious. So between the column of the fornix, which is clear here, the internal cerebral veins there, above the pineal gland, there is this space here. This area of the velum interpositum is a potential space that may distend. So distends with CSF fluid. When this region distends, it's known as the cavum velum interpositum. Cavum form an empty space or a cave. Knowing all these facts, let's go back to our abnormal case. So we have this fluid intensity area that separates the lateral ventricles. It does not extend beyond the confinements of the foramen of Monro on each side. If you go superiorly, you'll notice that the column of the fornix on each side is displaced superiorly and they are splayed apart. Going more inferiorly, you'll notice that it displaces the internal cerebral veins inferiorly as well. Now looking at the flare image where fluid is dark, the entire lesion suppresses without any soft tissue components. So this is pure CSF. On the coronal image, this is the lesion, which has the characteristic splaying of the fornices and the internal cerebral veins. And the lesion exerts non-significant minimal mass effect on the corpus callosum. Now correlating this with the sagittal T1, where CSF is dark, this is the corpus callosum. Here's the tictal plate of the midbrain, here's the pineal gland, and this is the CSF distended space. This is part of the column of the fornix, which is displaced superiorly, and this is part of a partially visualized internal cerebral vein, which is displayed inferiorly. So notice that it's an abnormality that's below the fornix, above the cerebral vein, and above the pineal gland, and in between the two ventricles, in a classic location for the velum interpositum. There is some debate about the terminology, but most think if this is more than a centimeter in size, which is the case here, instead of calling this a cavum velum interpositum, you'd call this a cyst of the velum interpositum, which is basically a CSF cyst. For juniors, make sure that this cyst is not big enough to cause any significant mass effect or obstruction of the CSF flow with subsequent hydrocephalus. And also make sure that the abnormality has a CSF signal intensity in all sequences without enhancing components, restricted diffusion, or soft tissues, since the presence of any of these components would suggest an alternative diagnosis such as a cystic neoplastic abnormality. Cavum velum interpositum, or a cyst of the cavum velum interpositum, are both typically incidental findings that require no further action. Of course, unless there is the rare condition when there is significant mass effect or CSF flow obstruction. Now let's review what we talked about today. We learned of a meningeal membrane that is known as the velum interpositum. For us to understand that, we talked about the lateral ventricle, the third ventricle, the septum pellucidum, the column of the fornix, the internal cerebral veins. We also learned that this area is a potential space that may distend into the cavum velum interpositum or a cyst of the velum interpositum if it's larger than a centimeter. And by that we end today's case. Thanks for watching. Your comments and interaction is always appreciated, and see you with more cases later. Hi there. This is a chest x-ray on a 30-year-old female patient who actually presented with abdominal pain. The finding is obvious. I'll give you a chance to look at it. It's a case that's good for juniors and seniors alike. Compared to the normal left hilum, the right hilum is superimposed by this opacity here. Now, description-wise, this is a large and well-defined abnormality that has homogeneous density. Now, given the location of this abnormality, this might be arising from the lung parenchyma or arising from the hilum. There are a few features that favor this being from the lung parenchyma rather from the hilar region. If this is hilar, it could be either an enlarged hilar lymph node or an enlarged vascular structure such as a pulmonary artery. The fact that this extends all the way into the lung is unusual for either entities, whether enlargement of a lymph node or a vessel. Another thing is that you could see the hilar structures and vascular markings through this abnormality, which tells us that this abnormality is either very anterior or posterior to the hilar structures. A third point is that most of the lesion is centered within the lung rather than being based on the hilar area. If this was arising from the lung, your main concern would really be that of a primary lung neoplasm, namely lung cancer. For this to be lung cancer, there are a few things that are unusual. First, the patient's age. She's a young female patient. Second, the border of this lesion is very smooth and well defined. For a large lung cancer, this would be unusual. When lung cancer is this large, you'd expect the border to be slightly more irregular or spiculated at least. Now, another finding that's unusual for lung cancer is the density of this abnormality. It's relatively low density. You could see all lung markings crossing through it. The point about density here suggests, although it's not definite, it suggests that this contains low density material such as fluid instead of soft tissues. And one thing that supports that this is more likely a cystic abnormality is this appearance here. We mentioned that the border is well defined, but notice that there is this interesting finding here. You have this thin line with an underlying lucency. You have the density of the abnormality, then the lucency that looks like air lucency, and then a very thin line which looks like a thin capsule. And here's the lesion on the lateral chest radiograph, showing a well-defined rounded appearance, homogeneous density, and this thin capsule with an underlying crescent of air lucency. Here's that sign again. You have this thin capsule, underlying darkness of lucency that represents air, and then the lesion itself. Now let's look at this on the chest CT. You see the abnormality here. Looking at the lesion on the soft tissue window, you notice that the abnormality is homogeneous, well encapsulated. And you'll notice that the density of the abnormality is low, consistent with fluid. So this is a fluid-containing cystic lesion. So based on this appearance here on CT, you don't have lots of differential diagnoses. So could the fluid here represent pus in the context of lung abscess? This is unlikely, since with a lung abscess you'd have much more lung changes surrounding the abnormality, and the patient would present in a different way. The patient would be sick and febrile. Another potential thought would be that of fluid within a congenital cyst. Congenital cysts are beyond the scope of what I want to discuss today. However, they're very rare, and they would very unlikely present this way at this age. Can this be central necrotic fluid within a necrotic primary neoplasm or metastasis, for example? That would be unlikely, since the presentation would be different as well, and you'd expect to see soft tissue components within the lesion, which is not the case here. Some of you have probably figured out the diagnosis, but let me give you the diagnosis clincher here. Let's go all the way down to the abdomen. And yes, the upper abdomen shows multiple similar cystic abnormalities within both the liver and spleen. Here's one hepatic cystic abnormality that contains a floating membrane within the lesion. Here's another with a detached membrane as well. So putting everything together, the final diagnosis here is multifocal hydatid cysts. Now just a quick account about Hydatid disease. The commonest hydatid organism is known as Echinococcus granulosus. So this type of parasitic worm exists wherever you have dogs and sheep. And humans could get infected by ingestion of fecal contaminated food or eating uncooked meat. The worm itself grows to form a large cyst which has 3 layers. Let's take this large splenic cyst, for example, to demonstrate those layers. On CT you cannot see them very well, so I'll help you by drawing. There's the large cyst here that contains the hydatid fluid. The most outer layer is actually a fibrous reaction. So the outer layer is a fibrous reaction by the organ itself, and that's what's known as a pericyst. Then you have a very thin inner layer that's called a laminated layer. It's basically a non-cellular layer. Finally, you'll have a very active, very alive germinal layer which actually produces daughter or smaller cysts. So from outside inside you have the pericyst, laminated layer, and germinal layer. The laminated and germinal layers could be called endocysts. Now that you understand that, this explains why you have this floating membrane kind of appearance. So this is detachment of the endocyst from the pericyst. And this would also explain the appearance that you saw on the chest radiograph, this crescent of air in between 2 different layers. With pulmonary hydatid, there may be communication with a small airway, and this leads to air insinuating itself in between layers. When air leaks into a cyst, it could separate the pericyst from the endocyst. So this is air in between the 2 layers. And this is a classic sign described with Hydatid disease. It's known as an air crescent sign or a meniscus sign. So what did we learn from this case today? We talked a little bit about an approach to a lung lesion that superimposes on the hilum and extends into the lung. We emphasized on how description might help you decide where the lesion is located and what are the possible differential diagnoses. We confirmed the diagnosis of hydatid cyst by looking at the CT and discovering other similar lesions within the abdomen. We talked quickly about the life cycle of Hydatid disease, the components in the form of membranes, and a few signs such as the floating membrane and the meniscus sign. Now I'll leave you with a question. We mentioned that the commonest type of hydatid is known as E. granulosus. My question to you here is about another hydatid form known as Echinococcus multilocularis. Echinococcus multilocularis. And the question is, why is E. multilocularis different than E. granulosus when it comes to imaging? You may post your answers here on Snapchat, or you could post it later when this is on YouTube in the comments section below. By that, I thank you for watching. I always appreciate your support, following, and interactions, and see you with more cases later.